Hello, everyone. Welcome to the session on long-term and some late side effects from lymphoma treatments. This Living with Lymphoma breakout session on understanding the treatment-related side effects will review some of the potential side effects experienced by patients following lymphoma during and even following lymphoma treatments, and provide some recommendations for resources and management methods to help reduce some of the burden of impact of these side effects. We really appreciate those of you able to join us live today. Now, before I go ahead and introduce our speaker, I would like to provide a bit of guidance about the Zoom software for those that might not be familiar with it. This virtual software does not allow for you to share your video or microphone, but if you do have a question, please save it for the end of this session for the Q&A portion. You can type your question into the Q&A section that is found in the bottom of your black toolbar on your screen, and your question will come straight to the moderator, which will be myself, and we will then ask it to the presenter live. I would now like to introduce and welcome our speaker for today, Dr. Peter Anglin. Dr. Anglin obtained his medical degree from Queen's University in Kingston and followed this with his clinical fellowships in internal medicine, hematology, and oncology. He has been in clinical practice in the Greater Toronto area and is currently a staff hematologist and medical oncologist, as well as the head of medical oncology at the Stronach Regional Cancer Centre at Southlake Health in Newmarket, Ontario. Dr. Anglin's clinical focus has been in hematologic and lymphoid malignancies and has many years of experience understanding the impacts and challenges related to lymphoma treatments. We thank you so very much for joining us today to share your expertise about the long-term impacts of lymphoma treatments and help patients to prepare for their follow-up journey. I would now like to go ahead and turn over the presentation to you, Dr. Anglin. Thank you very much, and please take it away.
Well, thank you for that kind introduction, and thanks to the organizers for asking me to speak. It just dawned on me that the reason they asked me to speak is I'm old, so I've seen the long-term effects of lymphoma therapies, but I'll take it as a compliment. I have been practicing for about 25 years, and I've done a lot of lymphoma work. So hopefully in the next 30 or 40 minutes, we can just touch on some real effects that people feel after they've been treated for a variety of lymphomas, and talk about some practical ways to manage those. So with no further ado, and I understand at the end, there'll be questions that'll be put forward with the chat or something. So great. So let's go ahead. Well, you know, we've got a lot of lymphoma survivors in Canada, and the number in the US is 900,000. So I cut that in 10, took 10% of that and said 90,000 in Canada, and that's usually pretty good for medical statistics. So a lot of survivors with lymphoma in Canada makes up about 6% of all cancer survivors. And the thing about lymphoma, when you really drill into it, it doesn't have the same depth of data on survivorship as the breast cancers and colon cancers and some others. So, you know, we've got work to do, and the literature is a bit weak on this as well, other than Hodgkin's lymphoma, which probably gets a little bit too much attention. We're going to talk about late effects, health problems that come months, years, or even decades after you've had your therapy. And the important thing is understanding what these late effects may be will help you be aware and interact better with your healthcare providers. Now, just to start, this was a 2020 survey, a Canadian survey that examined a number of issues around quality of life and treatment-related side effects in lymphoma patients, and it's a Canadian environment. Quite a number of patients, and we'll just go, this is quite interesting. So this is the side effects that patients have experienced, and it's by time. So side effects under a year, 1 to 2 years, 2 to 5, 5 to 8, more than 8 years. And so, you know, the acute side effects of various therapies, and in many cases, certainly historically, we've given a lot of chemotherapy, old-fashioned stuff. We've gotten more targeted. We'll get into that. And so a lot of the acute side effects that go with various types of chemotherapy, low counts, nausea, vomiting, and thinning of the hair, fatigue, nerve effects, lack of concentration or chemo brain, all of those acute things. But what we're going to explore today is what's happening down here, 2 to 5 years, 5 to 8 years. And there's still a lot of different symptoms around in terms of nerves and fatigue and other things that occur. So I'm going to touch on some of those. And again, this was Canadian responses in a Canadian setting, and how side effects over time can evolve and change after you've had therapy for whatever lymphoma. one other point I think that we need to talk about when we're talking about long-term effects is the real psychological stress of recurrence and the fear of recurrence, the concern of recurrence. And a lot of people have different ways that they cope with that. Some very healthy exercise, mind, body, eating well. This shows all positive coping mechanisms because there can be negative coping mechanisms as well, substance abuse, etc. But the issue is that the fear of recurrence is really somewhat unique to a number of the lymphomas, particularly the indolent lymphomas, CLL, etc., where people go into a remission with an expectation that at some point there's a good probability that there may be recrudescence of disease. So there's and then there's the curative therapy we give for the more acute lymphomas. They're cured, and once you get past 2 or 3 years, you're sort of out of the woods in most cases. So today, here's our brief agenda. What are these late effects? Who gets them? And we're going to hit some high points here: second cancers, heart disease, lung trouble, some hormone issues, a few other late effects. How do you reduce your risk of late effects? And I've just got a slide on CLL, only because that's a very common lymphoproliferative disease, and also because the therapies have evolved so much with CLL in addition to the other lymphomas, but it's probably worth a separate mention. So late effects, what does that mean? Months, years, or even decades after treatment, things can happen. And we're going to talk about cancers and various organ issues. And so, again, I just want to emphasize this quote: the risk of late effects might seem worrying, but knowing what conditions you might be at risk of and how to lower your risk will give you the best chance of preventing late effects or getting early treatment if these effects develop. So again, be aware of what to look for and prompt your provider, be your own advocate, so to speak. Who gets the effects? Well, that depends on a number of things. It depends on the type of lymphoma you had, the treatment you had, the type of chemotherapy, the schedule of radiation, the location, and then individual factors, because underlying medical conditions that you may have may increase the chances of long-term effects of whatever treatment that's administered by your care team. Now, having risk factors doesn't mean you're going to get late effects, and many people who we expect may have more side effects. They may have a weak heart, they may have lung issues, don't end up developing late effects. Now, one of the things that we emphasize for a lot of you, most of you that may have finished your treatment, is make sure it's always good to have a treatment summary of what you got, and that your primary care physician, your family physician, and other people that you interact with as you continue your journey are aware what those treatments are, because sometimes 10 years later, if something comes up, it can sometimes relate to some of the therapy that you had earlier. We talk about the lymphoma-related. So what type of lymphoma and where was it? So one of the interesting things is Hodgkin's lymphoma is about 1/5 of all the lymphomas. So the majority are actually non-Hodgkin's lymphoma. There's a slightly higher risk of late effects with Hodgkin's lymphoma. And that likely relates to the fact that historically, we used to use more radiation with Hodgkin's lymphoma and higher doses. And the historical data, which I'll talk about a little bit about radiation, doesn't quite apply going forward because fields are a lot smaller, doses are smaller, and the chances of side effects therefore are less. And I'll touch on that a little bit too. And then there's the treatment-related side effects. And I'm being perhaps a little redundant here, but it relates again, what kind of chemo did you get? What kind of radiation did you get? How long ago were you treated? If you're younger, you've got a longer way to go for things to develop. And certainly when in people like childhood and early adolescence, there's a lot of evolution in terms of hormonal evolution, et cetera. And people can be, say, much more susceptible to the hormonal aberrations that may arise from any therapies. What about individual risk factors? Well, that again depends on the age that you're going to get it, but it really relies on other medical conditions. So if you have, say, diabetes, and you've had that for some time, that makes you much more susceptible to the neuropathic or nerve effects of a number of the medications that we may use to treat lymphoma. Lifestyle is important. Heavy smokers have more lung problems. Excess alcohol can create problems. Obesity and weight gain can create a challenge and increase the risks for many treatments that we give. The last thing too is family history. And so if you've got a strong history of coronary artery disease, there may be a higher risk of cardiac issues that may arise from potentially from treatments down the road. Radiation late effects. We're gonna talk about that a little bit and how it can affect you. And then chemotherapy late effects, I'll get into that afterwards. And that of course relates to the drugs that you had and what we're treating you for. Second cancer. So let's talk about and what that means when we say second cancer is not a recurrence of the lymphoma or that you were treated for, but indeed a separate cancer that may arise some years later after treatment that may be related in part to your treatment. A couple of caveats there. We know that anyone who gets a cancer is at risk, at a higher risk over the baseline population of getting a second cancer. And that may represent a variety of things. Your immune surveillance may be a little bit diminished for eating those small tumors before they ever become a problem, and a number of other factors. So if say you had a colon cancer, you're immediately at risk for a bunch of other cancers. If you have a lymphoma, you're immediately, even if you get no treatment for it, you're at risk for a number of second cancers. But treatment and various treatments can slightly increase the risk of second cancers. And of course, when we treat patients, when we talk to you in the clinic, we're always weighing risks and benefits. And the vast majority of the time that we're recommending and discussing therapies with our patients and their families, we're weighing the relative benefits of not treating the lymphoma, your quality of life, and the small but real incremental risk of perhaps a secondary cancer related to that treatment. So it's again always a balancing act. If you take all Hodgkin's patients in total, you probably have double the risk of the general population of developing a cancer. If you take non-Hodgkin's lymphoma, again, that's about 80% of all lymphoma patients, about 1.5 times the general risk of developing a second cancer. And again, the important thing is you may have a higher risk than other people, but this does not mean that you will develop another cancer. And in fact, most people who are treated with lymphoma, most people that I follow, most of them don't develop a second cancer, but it's important you undergo routine surveillance as per a lot of people to make sure we don't miss something. The most common cancers that we see after lymphoma, and again, this is actually quite general, is acute leukemia. And that's in a very small proportion of patients. That relates to drugs that we may give you as systemic chemotherapy. Breast cancer and thyroid cancer largely relate to radiation fields if you had radiation to the chest, as does lung cancer. Non-Hodgkin's lymphoma is actually more common if you've had Hodgkin's lymphoma, and melanoma of the skin. Again, it relates in part to where you had radiation and again, the type of chemotherapy that you had. If we talk just about radiation and second cancers, if you radiate the chest, there is an increased risk, a little bit of breast, lung, and esophageal cancer. Head and neck cancer, again, it's where the fields are that other normal tissues get exposed to, such that many years from then, their DNA gets affected and they eventually may evolve a cancer. And if you radiate the abdomen, there's an increased risk of abdominal tumors, including colon cancers, pancreatic, and stomach. There's always a little higher risk of a skin cancer wherever the radiation field was for you, be it the chest, down in the pelvis, the abdomen, or even an extremity for that matter. Now, this curve, I'll just explain this to you. And this is for Hodgkin. And I've got 3 or 4 slides courtesy of Dave Hodgson who treats Hodgkin's lymphoma. And again, there's been an awful lot of work on Hodgkin's lymphoma because that was actually our first curable malignancy. And the radiation therapy to cure Hodgkin's lymphoma was actually pioneered here in Toronto. So there's a real historic link to radiation therapy in Hodgkin's. So I'm going to show you a few slides relating to that, understanding that most of you watching probably haven't had radiation to your chest, depending on what your lymphoma was, but some of you may. So if you'll bear with me for a few slides, I think it's important historically. So here's a group of patients, about 1,500 from the States, who had early stage Hodgkin's lymphoma, so it would have been in their chest. And over about a 30, 40-year period, they were treated. And most of these would have received radiation. And you'll see this is cumulative incidence over time. And this is 10 years, 20 years, 30 years. And what happens is you start to get out at 10, 20, and 30 years. These patients have a substantive chance of a second cancer at about 1% a year. And this would include a breast cancer, lung cancer, et cetera. They also have issues of heart problems that can develop later. And then, then you see even other lymphomas developing. Now, this is older treatments, bigger fields, higher doses. And for those people who would be receiving radiation to the chest now and in the current era for Hodgkin's or non-Hodgkin's lymphoma, these curves would not apply. And I want to emphasize that. But I show it showing that there is a relationship between treatment and cancer. And in fact, here's, again, this is just another slide showing the same thing. But the old way we used to treat Hodgkin's lymphoma was called the mantle field. This is a person, this is their chest, and this goes out to the axillary lymph nodes under the arms, and it includes the neck nodes as well. We call that a mantle field. Now, what's happened over time is for Hodgkin's lymphoma, the fields have gotten a lot smaller. And so we've moved to what we call involved field radiation therapy. The fields are a lot smaller and the doses are smaller. And that means the secondary, and this holds not just for Hodgkin's lymphoma, but the use of these conformal fields, of which they use very fancy computer software, minimizes dose of radiation to whatever site's being treated and is able to focus the main strength of the beam right on the lymphoma or tumor itself, while minimizing exposure of radiation to surrounding tissues. And this is just one more fancy drawing to show you how these days, how planning is done to treat a lymphoma of the neck, for example, if it's felt that radiation is appropriate. Again, many lymphomas are treated without radiotherapy. I want to emphasize that. But in this case, the dose, we use the term gray here. It's called 30 gray is the dose that we're giving to the tumor. The heart, which is down here, does get a bit of radiation, and that can potentially have long-term deleterious effects. And then the breasts, which would be in this area, do get a little bit of radiation as well. And in fact, and here you can see on the schematic here, and that can increase a small amount, but over long term increase the risk of breast cancer for people getting radiation. But again, the newer radiation techniques really aim to minimize exposure to good tissues. And while this illustrates it for the chest, these same themes would hold wherever you're getting radiotherapy. And just one study showing, so this is a study showing cumulative incidence of second cancers over time, 10, 15, 20, and you'll see the old fields, this was how lots of cancers developed, almost 1% a year. But when you make the fields smaller, the incidence of second cancers drops substantively. And this is indeed what we see going forward. And this is, again, thanks to Dave Hodgson, who's a radiation oncologist who actually specializes in the long-term treatment effects, in particular around Hodgkin's lymphoma. And so the last slide, and again, this relates to all lymphomas, but the question is, you've got a young patient and you really want to minimize the dose to the breast, minimize the dose to any normal tissues, and any time that a therapy is being recommended for whatever lymphoma, one has to weigh the potential risk of breast cancer, which may go up now in today's ways, in today's doses and fields, it goes up just 5%, not up to 20 or 30%. And then one would have early breast screening in a patient who's thought to be at risk. So again, I think we've made some real headway, but we do think very carefully about treating younger people with radiotherapy. I want to emphasize something because a lot of people, a lot of families, may recognize that one of their loved ones have had some radiation, but there's many different types of radiation you can get. And one very common type of radiation for low-grade lymphoma, which is a lymphoma that's indolent, that can play out over many years. And occasionally there might be one little area, patients may not require any treatment, but there might be one area that's growing and bothersome for a patient. And we've learned that just 2 treatments, they use the term boom boom, it has a little boom to it, I guess. But it's just a 2-day treatment, and with little toxicity. It's very good in patients who have advanced disease, but there's one area that's bothering you. And this has almost no side effects whatsoever. And that's a lot less than the 24 gray that is used. Now, sometimes for low-grade lymphoma, you may have very localized disease. You've been staged, there's no disease elsewhere, then you will give the curative dose of 24 gray because there's a real chance of potentially curing that low-grade lymphoma. But for more advanced low-grade disease, just a little dose sometimes for a problematic neck node or perhaps in the groin, very helpful, almost no long-term toxicity. So again, different types of radiation, different doses, very important for long-term side effects. Now, I know you're never supposed to apologize for your slides, but the only thing I want to take from this slide, and I'm not going to, don't worry about all the details, but different lymphomas have different risks for second cancers. And this is actually a publication from the Journal of Clinical Oncology about 11 years ago. And what it looked at was second malignancy rates after non-Hodgkin's lymphoma or CLL. And they found a few interesting things. They found that, treatment for CLL or follicular lymphoma had an elevated lung cancer risk and some of the explanations weren't clear. They were talking about aberrations of the immune system, et cetera. They found that cutaneous melanoma was more common after follicular lymphoma and CLL treatment, but not so much for diffuse large B-cell lymphoma. Again, this is a more aggressive lymphoma, but a third of all the lymphomas. And then lastly, there's always some concern about acute leukemia after we give systemic chemotherapy in particular, and that can raise the incidence of secondary leukemias a little bit. And certainly we saw that for follicular lymphoma and diffuse large B-cell lymphoma, but not so much for CLL. So the point of this slide is that there's different risks for different lymphomas over time. And I won't belabor that anymore. So I showed you radiation, and now what about chemotherapy and second cancers? Because the chemotherapy in particular increases the risk a little bit, excuse me, of leukemias, which are blood cancers. And one of the agents that are class of agents that can do it are alkylating agents. And these are really ubiquitous in many of your therapies. It's in CHOP for lymphoma. It's in Bayacop and dose-adjusted R-EPOCH. This is for Hodgkin's. This is for non-Hodgkin's. ABVD has dacarbazine in it. Bendamustine and Rituxan is really the standard of care that we use for advanced lymphoma frontline right now. So this is a very common regimen. Some conditioning regimens for patients who are getting autologous transplants, usually in patients who've relapsed and we're trying to salvage their lymphoma. Oral chlorambucil is used a lot. Ifosfamide and so all of these all fit into a class of drugs called alkylating agents. And when you get those medications, there is a small but real risk long-term of developing a leukemia. When I say what does small mean, just a few percent. But compared to the general population, your relative risk versus the average person on the street who didn't receive these drugs is elevated a fair amount. And we see it also from doxorubicin, which is again part of CHOP. A lot of patients both get doxorubicin and cyclophosphamide for a number of different treatments, including diffuse large B-cell lymphoma. Again, we always are weighing risk-benefit, but we want to give the therapy that cures you of your lymphoma up front at a small but real risk of potential issues down the road. What about heart disease after lymphoma? And Hodgkin's has a higher risk 7 times over the general population, non-Hodgkin's 5 times. This probably, as I mentioned earlier, reflects the fact that Hodgkin's lymphoma historically has administered much more radiation to the chest than the non-Hodgkin's lymphomas have. And so I think there's a bias there reflecting radiation effect and historically bigger fields and bigger doses. So I may be a little bit redundant. This is in part to reassure a lot of you that while these issues are relevant, that you're getting smaller fields, smaller doses, there's still some risk, but probably the magnitude of the risk now is becoming mitigated more and more with the more sophisticated fields that we give. Often heart issues don't arise for a decade or more. They can come sooner. Very occasionally, the adriamycin or doxorubicin can cause a cardiomyopathy acutely. So what increases your risk of heart problems if you're going to be getting therapy for a lymphoma? And it's, risk factors for really, these are cardiac risk factors as well: cholesterol, blood pressure, diabetes, smoking, overweight. These factors all contribute to heart disease just in the setting of a higher risk of coronary artery disease. So again, we emphasize to all our patients is that, living a relatively healthy, not an extreme, but a relatively healthy lifestyle is helpful overall for your long-term. One of the things I've learned in people who are smoking when they do develop a cancer and require therapy is it's awfully hard to take the stress of a new cancer diagnosis, start some systemic therapy, whatever it may be, or a treatment protocol, and also quit smoking all in 3 or 4 weeks. And so you have all of these pressures on people. And so again, that can be a challenge for people. So what about if we radiate the heart? What can happen to the heart? Well, radiation can affect potentially all parts of the heart. It can cause thickening of the valves. It can cause some narrowing of the coronary arteries, both the main arteries, but also the small arteries that penetrate in the heart muscle. It can sometimes cause some inflammation around the outside. We've heard a lot about pericarditis because of COVID and the rare association between post-vaccination pericarditis, but that refers to actually inflammation of the sac around the heart. And then sometimes the heart muscle itself can be weakened even by radiation. And if these effects may not be seen acutely, they may present as valvular heart disease or coronary artery disease 10 or 20 years, potentially after your treatment. Again, not in all patients by any means, but you may be at a little bit higher risk for these things. So something to be aware of as you speak to your family physician and have screening tests that are appropriate. That's for radiation. Chemotherapy. The one thing about chemotherapy is the drug doxorubicin. It also goes by the name adriamycin. And doxorubicin for diffuse large B-cell lymphoma and Hodgkin's lymphoma, we don't use it much for follicular lymphoma. It has, it can, in about 2 or 3% of people, can develop an issue where the heart muscle becomes acutely weak and you develop something called a cardiomyopathy. In many patients, it passes and it improves over time. But there's a whole question of how often should we survey patients with echocardiograms to pick this up. We do them at baseline often. A lot of people do it halfway through treatment, but there's no set way to screen for cardiac disease in patients receiving anthracycline. In my practice, I do it at the beginning and the end, and for patients at higher risk, I might do it in the middle. But with each clinical assessment, I ask about, are you short of breath? Have you got ankle swelling? The patients are examined, et cetera. This is a little, if you've got pre-existing heart disease, again, there's a higher risk that you might have clinically important cardiotoxicity with your treatments. Again, the caveat, most people I treat for cure for large cell lymphoma and Hodgkin's lymphoma do not develop clinically important cardiomyopathy from the adriamycin. Because you could say, well, why don't you just take the adriamycin out, which is doxorubicin? Well, this happens to be one of the most important drugs to give for diffuse large B-cell lymphoma and Hodgkin's lymphoma. So we don't like to leave that out. And on risk benefit, weighing both of them, you're much, much better off to get the therapy if your health team deems you appropriate for such. And this, just to reassure you, because a lot of you may have received adriamycin, but this is heart failure for patients who are congestive heart failure free. And long and the short is over, this is like 8 years out from treatment. And there's only a few percent different in patients who've developed heart failure in patients who got adriamycin and those who didn't, okay? Now, I'm not minimizing the effect on those 5% of people that maybe have been affected in this setting, but it's not a huge difference over time. But there is a signal there that if you've had chemotherapy with adriamycin, some patients down the road can develop some heart issues. And, often with cardiologists following you up, appropriate therapy, people can live normal lives. What about the lungs? So this is a chest x-ray, heart in the middle, right and left lung, patients facing us. And this is what a CAT scan looks like. That's the backbone. That's sort of the top of the heart and structures, and that's the right lung and the left lung. And this is what a chest X-ray, which there's slightly increased markings that we're not used to seeing, but when you do a CAT scan, you see all this white stuff in the lung fields that shouldn't be there. This is bleomycin pneumonitis from, again, therapy from Hodgkin's lymphoma. And it happens in about 10% of patients. So, it's something we take very seriously. We can see it and we see it with bleomycin containing regimens. You can get actually pneumonitis from a number of different drugs. It's most notorious with bleomycin, but you can get it with rituximab. You can get it with cyclophosphamide. So you can see it. Usually it manifests itself while you're on treatment. So if you're done your treatment, it's usually not an issue. If you give radiation to the chest, you can get some fibrosis of the lung, but it's usually more limited to the fields of the lung itself. And so, again, one of the themes that we talk about is as therapies evolve for your lymphoma and how we treat it, we're always trying to minimize, optimize cure and long-term progression-free control with minimal toxicity. So what we've done, for example, is there's a number of therapies, most commonly in Hodgkin's, where we do a PET scan after a couple months of therapy, and then often we adjust the therapy down or take out a drug like bleomycin. The other thing that's happened, as I've showed you earlier, is that radiation fields have indeed gotten smaller over time, again, to mitigate potential side effects. Hormone problems, these can be pretty common over time. And, hypothyroidism, that's much more common if you've had some radiation up in the head and the neck. That can actually occur in up to half the patients who've had some form of radiation up there. So it's important that over time that someone keeps an eye on your thyroid indices, your TSH. Often for most general health exams, that's included in the screen. But again, your primary care physician should always be aware if you've had radiation in the head and neck. Diabetes, we see, blood sugar control goes off with a number of our systemic therapies. Sometimes if you've had radiation to the upper abdomen, that can affect pancreatic exocrine function and lead to glucose intolerance and early diabetes as well. The last one I'm going to spend a little bit of time on, because this is something that's very common, and the issues around fertility preservation in a younger woman who's receiving a form of therapy for their lymphoma and is interested in maintaining fertility, having a family. And the second more common issue is that of premature menopause. What does it mean for people, and what do we do about it? So average menopause, at least in Canada, is around age 51. If you're less than 45, they call you early. And if you're less than 40, they use the term premature ovarian insufficiency. These are just technical terms. But both chemotherapy and radiation can have an effect on ovarian function. And, a variety, some of you may be familiar with these symptoms yourself, or, I'm at an age where a lot of my significant others and associates are starting to feel this way. And so there's a variety of symptoms that can be experienced as people reach menopause. It's something that primary care providers are very comfortable seeing and managing. What we do know is that if we give treatment to younger people, the chances of them maintaining their regular periods and not going into premature menopause is much less. But when we treat people, once we're treating people over 35 or 40, first, it depends on the type of chemotherapy. So this is the chances of having no periods 4 years after chemotherapy. So this is a chemotherapy regimen that was light. And you'll see even at age 40, people got chemo, only 20% of them developed ovarian failure. But if we give stronger chemotherapy, then we have a much higher incidence of putting people, particularly over 30, into an earlier menopause. Now, it may just be a few years difference, but some patients, again, can have fairly significant menopausal side effects. And so that becomes an issue for quality of life. And it's something that needs to be managed both by their primary care provider and occasionally with an endocrinologist being involved, but usually it's the primary care provider. Not all regimens affect the ovaries the same. So early menopause, here's some common regimens, and again, CHOP, ABVD, these really don't, most women who are menstruating will start to menstruate again and not really have early menopause with these. But all of a sudden, if we're giving more Bayakop these days to Hodgkin's lymphoma, You know, it was interesting. Bendamustine Rituxan, again, that's probably the most common frontline regimen we give for low-grade lymphoma. I couldn't find good data on the incidence of menopause or precipitating early menopause with that. My anecdotal experience giving it to quite a number of women who happen to be younger and it has not been a big issue in my practice, but again, I couldn't find data on it, and I thought it was important to mention. Now, we're getting into the era where we're giving more targeted agents. So what do I mean by targeted agents? Antibody therapy, some of the oral pills and things like that, and many of them have much less risk to the ovaries. And of course, immunotherapies, which we use in Hodgkin's a lot, but not so much in the non-Hodgkin's lymphomas, but they don't affect the ovaries very much as well. So again, there's a lot of heterogeneity in the drugs we give and who's affected. And so what to do, you know, there's the things that you can do for yourself, you know, and some of these, they may sound like motherhood statements, but they're actually real and I think valid. And I certainly spent some time coaching my patients, you know, on a healthy lifestyle and moderation, et cetera. But the other piece around interventions, there's a lot of different things that can be done to improve quality of life if you're having adverse, or if a patient's experiencing some, you know, adverse effects from premature menopause that's affecting their quality of life. And so I really encourage patients to get involved, and primary care physicians, family docs really have a lot of experience in this area. And I'll often in my notes have the patients go back to the family doctor for support too. One of the things that I would mention that if we do precipitate early, so if someone goes into menopause, say at age 41 rather than 51, there is a higher incidence of thinning of the bones, and there's a little higher incidence of cardiovascular disease. So then the question about how do we mitigate that and what's the role of hormone replacement therapy? Disclaimer right now, I'm not an expert on endocrine therapies and replacement, and I really work with the primary care providers to provide that counseling. But again, important for you to be aware of and important for your primary care provider to be aware of. Just a few other late effects of therapy, fatigue, I'm going to touch on that. Neuropathy, we see that. Very occasional patients have persistent numbness, tingling in their feet and their toes that doesn't go away. And there's occasional patients that are very sensitive, and it does affect long-term quality of life. Most patients that are treated with for lymphoma do not. Where I see this the most is patients that have had relapse and required salvage therapies and other therapies, and then cumulative effect of a number of drugs that are toxic to nerves. We don't see it so much just with a single round of treatment for their primary tumor. Hypertension can be caused by a number of medications. That's treatment specific. Lastly, eye issues. Exposure to steroids through your treatment increases your risk of cataracts. And there's also an issue if you've had some radiation around the head and neck in terms of cataracts as well. I don't want to minimize this issue of fatigue. I showed you at the outset of this talk how long-term, when asked subjectively, many patients say that fatigue is a challenge for them. And certainly when I'm seeing my patients in follow-up for lymphoma, I think it's important that, you know, you just, oh, you'll get over it. I think it's important they need a comprehensive evaluation. I really make sure that they've seen their family physician, had a full history physical, blood panel, and then, you know, make sure there's not other mitigating illnesses at play. Occasionally, hypo or low testosterone levels can be contributory. I mentioned menopause. Big issues, the thyroid, always screen that. Obviously, if you run around with a blood sugar that's very high, that doesn't make you feel well. Again, blood work to screen for low hemoglobin. Are they on too many medications? Some of my older patients have some polypharmacy, although I must say the issue of polypharmacy or many medications, that seems to be diminishing these days as more and more physicians are aware that sometimes too many medications is too many medications. I think lastly, and very importantly, you know, in terms of mood, depression, and anxiety, which are real in someone who's been treated and has fear of recurrence and other issues, these need to be explored and get appropriate counseling, support, cognitive therapy, and potentially drug treatment if needed, supervised by your family physician, and sometimes we'll get a psychiatrist involved as well. So pulling it back. So what can you do to reduce your effects? I think, we've talked about being aware about your health, but really, I guess, we're in this sort of post-COVID era. And I heard something in the news about everyone has to see their family doctor again because everyone was virtual. But I think what I've seen even before COVID is people, because they were coming to see us regularly, they kind of said, I don't need to see my family doctor, I'm good. You absolutely do. We cannot provide comprehensive care that you need long going. So it's really important to stay with your primary care provider. And it's important for us to communicate to them what's, the treatment you've had and just things to be aware of. One of the things that goes for everybody is that make sure you get primary screening at least appropriate for your age and your cohort. So, women over 18 or 20 should be getting pap smears. Screening for colon cancer is appropriate for you. Screening for breast cancer, prostate examination of men over 50. All of these are important as primary prevention, whether you've had a lymphoma or not. Understanding your risk is a little bit higher than the population. Again, I want to emphasize again, long-term cardiovascular and bone health, again, which would be overseen by your family doctor, and the lifestyle choices. I'm sorry, I'm sounding a bit redundant on this. Just a brief note on, I've got probably another 5 minutes and then we have questions. CLL, it's changed so dramatically. I gave it its own slide. I've been treating CLL for 25 years and up to 5 or 6 years ago, we gave the bendamustine Rituxan or this cocktail of drugs, fludarabine, cyclophosphamide, Rituxan, or this one, which was very effective, pills and an antibody to sort of older patients. And often the CLL could go into remission for many years. In fact, FCR still cures some people with CLL up front if you have good risk CLL. What's clearly happened with CLL is we've gotten a more targeted therapy and a trend to less of these older drugs, the old alkylators and things. And in fact, now for CLL patients requiring therapy, upfront therapy is usually an oral pill called a BTK inhibitor. 2 of them, ibrutinib in Canada, calibrutinib's the newer kid in the block. When you take these drugs, you don't just take them for 6 months. You might take them for 5, 6, or 7 years. In fact, one of the original trials looking at these drugs, the median time of people being on drug was 6 years or more. And so with time, these develop their own set of side effects too. A little higher incidence of atrial fibrillation, hypertension, a little bit more tendency to bruise and bleed, sore joints. So in an era of ongoing continuous therapy with what we call targeted agents, these agents are better in a number of ways, but they can have cumulative side effects over time that really require active management by us as the healthcare team prescribing them and awareness of you of what are these side effects. And there's some other drugs that, venetoclax we're using certainly, and a number of drugs that are starting to evolve in this space that have really changed the long-term outlook for CLL. So the important thing is know the drug you're on. Have some ideas of what the side effect profile is. And bring it up when you're talking. Often we see patients on these drugs about every 3 months. I tell my patients to have their own blood pressure cuff and take it at home, but don't be shy to bring up the symptoms to your health team, because there are ways to mitigate a lot of these things. Autologous stem cell transplant. Some of you may have had a transplant or known someone, and we use that generally in the lymphoma setting for relapse disease with a view to still trying to cure the lymphoma. But it does mean that you get higher doses of more traditional older chemotherapies. Often the conditioning regimens do involve total body irradiation. And so the incidence of cataracts in this population is much higher. Incidence of infertility is much higher. And so these are real issues. And I mentioned, if you have a transplant, you have all of the previous things I mentioned from your previous treatments, and they get compounded somewhat with the transplant. It does increase your risk of second cancers as well. Now, just to be clear, I have seen many, many, many people have autologous transplants over 25 years now. And many patients, it's, the first 3 to 6 months, it takes time to get back to your mojo. But a lot of patients get back to where they were. And the majority of patients, can have very good quality of life going forward. newer treatments, just to my theme that treatments are evolving in all of the lymphomas that are more specific and not the kind of poisons, if you will, of our old chemotherapy. And they go by a bunch of different names here. Here's an example of how an antibody works and targets a particular cell and kills it. It may be that with these newer treatments, the late effects may be less, but it's early days for a lot of these. And, 5, 10, 15, 20 years, we've got to keep an eye on what these longer term side effects are. But indeed, the effects perhaps, and we hope, will be less. Last thing, what about resources for you to seek? Lymphoma Canada does have some resources. By virtue of you being on the site, maybe you've seen some of this, but they do have a guide, Life Beyond Lymphoma. Really interesting. It gave me a chance, just getting ready for this talk, it allowed me to take a look at that and see what was available. So I'd encourage you to take a look at that. And then here's just sort of 2 or 3 other sites I found. This is Leukemia and Lymphoma of Canada. Lymphoma.org is an American site. And I actually took some of the material from this talk, not just from Lymphoma Canada, but this is a UK site, which I found interesting and quite helpful as well in terms of long-term side effects management, et cetera. And there you have it. So I think I did all right. So about 45 minutes, that's what I said. I'm going to stop now and I'll go back to our host.
Wonderful. Thank you so much for your absolutely excellent presentation and sharing a lot of your expertise and guidance about some of the different challenges or treatment-related side effects patients might experience into their follow-up journey. We appreciate a lot of the information that you provided on some of the management techniques or coping mechanisms for some of these side effects and informing patients on how to recognize what these signs or symptoms that they might be experiencing are and how to actually seek and communicate with their medical care team about these to try and work together to resolve them. So I would now like to go ahead and open our Q&A. As a reminder to our audience, you can still continue to ask your questions by typing them into the Q&A section, which is located at the bottom of this screen in a black toolbar through the Zoom platform. Please, of course, click submit and questions will be asked in order of receipt. And we already are having some questions come through. So let's go ahead and just get started. So the first question we have is it possible that I may experience a side effect like fatigue, for example, for the rest of my life? This person had tried many different management techniques and all of them haven't seemed to get them to the level of fitness and activity that they had prior to treatment. So is there anything that they can kind of do at this point?
That's a theme that is not so uncommon. 2 negatives, meaning I've certainly heard that from many patients over many years. Mm-hmm. And I guess I don't have a specific answer for you other than emphasizing what I had mentioned earlier about, having a comprehensive evaluation with your primary care doctor, ruling out everything else. I always bring up the question of mood, anxiety, although that's often not a factor in many patients just don't feel they can do as much. But I don't, beyond the other thing that's becoming much more sort of in the, trendy, and it seems to be effective for some patients, is cognitive behavioral therapy to help manage and cope with fatigue that's real for them. And that's probably one thing I would suggest you maybe start with asking your primary care physician about. I've had a couple of patients go that route with some benefit.
Okay, great. Wonderful. That's a fantastic suggestion and might be something people haven't thought about trying. So that's a great suggestion to speak about with your healthcare team. The next question we have is, I've heard of palliative care and not sure if this is something that is involved throughout treatment, if experiencing certain side effects, or is it known as sort of, when there isn't really anything left to do, that's sort of the option that's used. What can you kind of share about palliative care and whether it can be incorporated to help with some of these, to help manage some of these side effects?
Yeah, so I think I call it pain and symptom management. And there's palliative care, pain and symptom management, which is the same team. But I think the issue of quality of life and symptom management starts with the day we see you and your diagnosis. And many patients sail through therapy, have minimal side effects, and are happy to carry on. And a lot of patients do have a lot of physical challenges with the treatment. And so in that setting, it depends what environment you're in, but we will involve our pain and symptom management team to support you through treatment. And, they often have tricks and things that I'm always learning from them. So I think they're a part of our team, and we deploy and get patients involved with them. Now the trend is to get people involved sooner rather than later, rather than, people ever tell you having horrific side effects and nothing's working. Oh, maybe you can see the pain and symptom management team. We have them see the threshold has dropped. The term palliative care, I don't think it's a bad term. I just think in this instance, I call them the pain and symptom management team. Palliative care, and then there's end of life palliative care and supportive care. And that's living life the best you can if things are becoming a challenge and the disease is progressing. And that's kind of a different kettle of fish than when we're giving them the treatment up front and you're having real side effects affecting your quality of life. But there's a role for that supportive team in both scenarios. I hope I answered the question.
Yeah, you did. I think that's a really great terminology to use, moving forward, just because a lot of people associate palliative care automatically with it being end of life care, and that's not necessarily the situation. It can be involved throughout your clinical journey, right? So that's fantastic to know. So the next question we have is there a relationship between rituximab therapy and an elevated heart rate? We just noticed, having a high heart rate following a moderate walk, for example, when recently receiving rituximab, but then it was fine the next time their treatment sort of came around. So is that something you commonly see?
Not that I'm aware of, but there's causation and association. So rituximab per se doesn't cause a rapid heartbeat, but the reason you're getting Rituxan is you've got lymphoma. Are you anemic? There's a bunch of other things that may contribute to a rapid heart rate. So there's more to that, but per se, rituximab itself doesn't cause a rapid heartbeat.
Okay, great. So maybe something.
Unless you're having an infusion reaction, but that's separate. And personally, the first dose, as a lot of people on this call maybe who've had rituximab know, that first dose of rituximab can cause a little bit of side effects and stuff, usually effectively managed by the team.
Great. And actually a second follow-up to rituximab therapy in particular, sometimes I think it can be given either intravenously or subcutaneously. And some patients have noticed sort of a reaction at the injection site, whether it's a rash or whatnot. What are your recommendations moving forward? So should the patient continue to receive that method, or should they change back to intravenous because it seems to be, working with them without a reaction?
It depends what your reaction is. So most people have a local reaction to subcutaneous rituximab. And so I've probably maybe 3 or 4 times, and I give a lot of rituximab, I've had to convert back to the IV but often it's just working with your nurses. And most of the team that administers this, they really are experts in this. So I generally try to stay with the sub-Q because it's nice. It's given in 5 or 10 minutes versus 90 minutes to 2 hours, and it's a lot more convenient in that way. If it's really problematic for you, yeah, you can go back to IV. I've had a couple of patients really want, and I've respected their wishes. So I think it's really an individualized decision.
Okay, great. So thank you so much for clarifying that. So I think we have maybe time for 1 or 2 more questions. The next question we have is, are you at higher risk for secondary cancers if you've received, multiple therapies versus maybe you just had one treatment and you're in remission following that? Is kind of having more treatments at risk for having or developing secondary cancers?
Yes, there is an association between cumulative dosing of drugs like those alkylators I showed you, then even the adriamycin and things, but you can only get so much of that. So there is a higher doses you get, the higher cumulative doses does increase your risk somewhat of secondary issues, cancers, leukemias, et cetera.
Okay, great. Thank you so much. And I think the last question we have for today is sometimes, of course, to treat certain side effects, there are medications. What happens when that patient starts to have reactions or side effects to the medications that's already treating a side effect? What do you kind of do in that scenario?
stop medication. I've seen that. Yeah. I mean, people are, I've had people that are, super sensitive. I've given them steroids, but they're sensitive to that, or they take Gravol and they get nauseated. So, I think it's just, if a drug is not working for you, you stop it, talk to your healthcare team. What's an alternative? Because, people can have unusual reactions to drugs. I've seen it over the years. And you stop it and you talk to your healthcare team about alternatives.
Okay, great. Wonderful. So I just wanted to thank everyone who was able to ask their questions. I think we're about out of time for today for the questions, but thank you so much, Dr. Anglin, for joining us today, taking the time to share your expertise and answer some of these live questions as well. I wanted to thank all of our live audience members. If you do have any follow-up questions that we might not have been able to answer live today, please reach out to us via email at info@lymphoma.ca